everyone about yourself.
Okay, my name is Naeam. I'm a certified registered nurse anesthetist. So I practice anesthesia. A prerequisite to being a CRNA, a nurse anesthetist, is you have to have your bachelor's in nursing. So that's where I met Charmaine. We were nurses back in Roanoke Beaumont Neurotrauma ICU back in 2002. I decided to further my education in September
Night shift, man, getting it.
in September of '05. I went to University of Detroit Mercy, where I got my master's in nurse anesthesia. Uh, and I've been working at St. John, it's now called Ascension Macomb, Oakland, Warren campus, since December 3rd of 2007, providing anesthesia services. And what an anesthetist does is I can function like an anesthesiologist. However, I didn't go to medical school, so I'm not an anesthesiologist, but I can do the same things that they do. So I actually am the person who puts people to sleep for surgery. So if somebody was having their gallbladder out, or you can have a colonoscopy, or you could even be having heart surgery, I'm the person who puts you to sleep, stays with you during the whole time. I have autonomy. I'm trained in what drugs and medications to give. And then at the end of the procedure, I'll wake you up and take you to recovery, except for a heart case. We don't wake you up in the room. We take you to the ICU direct. So that's that.
Wow. That's pretty dope. That's pretty legit. Yeah. Like how do you feel about your career? I'm sure you love it, right? Or you wouldn't be doing it.
I actually do love it. It's great job satisfaction. It's the best thing that I could have ever decided to do. When I was looking at things to go back, I always knew that I wanted to get a master's and, pursue higher education and make a little bit more money. And so when I was looking into what areas there were, I was considering doing medical law, but I didn't know anybody personally. And being our background in ICU, which is intensive care unit, it's kind of the feeding pool for anesthesia. And so I'd actually had the benefit of shadowing an anesthetist. And I'm like, you know what? This is what I want to do, because Charmaine can even vouch. When we were in the ICU, we did everything. We had patients on all kind of drips, and we're saving lives. The only thing we weren't really doing was intubating somebody. So I'm like, intubating somebody, which is putting the breathing tube, the endotracheal tube in. I'm like, that's a skill. I can learn that. This is what I'm going to do. It was a lot more complicated than that going to school. It was the hardest thing that I've ever done, but it was the most rewarding thing that I could have done.
Right. Let me just jump over here to our comment thread for a second. Steven says the Sandman. What's that mean? The
It means
Sandman.
basically sweet dreams, putting somebody to sleep.
Oh, what's up, Steven? Thanks for joining us. Wayne Bradley, what's up, superstar? He says, my grandfather was the first Black licensed anesthesiologist. That is dope. Dang.
That is dope.
Yeah, that's pretty legit. That's pretty legit. Okay, so my next question I wanted to ask you, talk about what ventilators are. I mean, we may have heard that term, but if we haven't, I swear this pandemic caused everybody to learn what a ventilator is. We know that, we just know that hospitals need them, have this great need for them, but explain what they are, what they're used for, and also explain why it's been basically the staple in treating these COVID-19 patients.
Okay, so as you know, with COVID-19, you can have different signs and symptoms, but what the virus does, it actually attacks your respiratory system. So as it is attacking your respiratory system, your oxygen demands increase, meaning you become short of breath, you're having difficulty breathing, you have an increased heart rate, you're panting, and you basically feel like you're suffocating. So what we do initially is we give somebody some supplemental oxygen. You might originally start out with the nasal cannula, which is the little two-nose prong thing that goes in your nose. And that only can give you so much oxygen. So as the disease progresses, we will attempt to probably try to give somebody a non-rebreather mask. That's the most oxygen that you can give a patient where they're actively breathing on their own. Unfortunately, what has happened as the disease progresses is these people can no longer breathe on their own. They're like basically drowning in the secretions. And, you have to basically help them out and take over for them and breathe for them. So that's what a ventilator does. A ventilator is a system that breathes for a patient that can no longer breathe for themselves. So what you have to do in order to be put on a ventilator, that's where I come into play. I come and intubate the patient. So intubating means I take basically a little blade in my hand. It's called a laryngoscope blade. I put it in the patient's mouth, and when I lift up real hard and strong, I can see their vocal cords. Their vocal cords look like this. And then I stick the endotracheal tube in their vocal cords. We make sure that the tube is in place by monitoring end-tidal CO2. We monitor that their oxygen levels actually come up, because the majority of, well, actually all the time, these patients' oxygen levels are falling. So you're going to see that their oxygen level rises on the monitor. You also look for chest rise, and you take a stethoscope and listen to make sure that you can hear breath sounds on both sides to make sure that the tube's in place and everything. But again, when somebody is placed on a ventilator, that means that
That's not bad
they're in
news.
trouble.
That's not a good thing.
It's not a good thing. It's not a good thing.
But it doesn't mean it's the end of the world either,
It does
because
not.
right.
Actually,
But
it used to seem like that from this disease. When you were looking at the literature from Italy and from France, a lot of those people were dying initially that were placed on the ventilator. It almost seemed like a death sentence. But I can honestly say we've been getting quite a few people off the ventilator. So that is a very rewarding feeling, to feel like, oh my God, they're gonna make it. They're gonna make it.
because
Again,
I heard in New York a lot of those patients weren't coming off the ventilator. I mean, that possibly could be true. Do you know?
it is true. A lot of people, unfortunately, who did get put on the vent did have not made it. That is true. That is true. But there are some people who are actually making it off the ventilator. And I'm not sure if it's because it's a combination of different drugs that these people are receiving. Because you guys probably have been watching the news and stuff, that they've been giving everybody the drug that Trump recommended, the Plaquenil, also an antibiotic, erythromycin. Also, they've also started introducing, I can't think of the name of it, but it's like an antiviral drug, like an HIV type medicine or whatever. They've been giving people that medicine or whatever. And they've also been doing high doses of vitamin C, vitamin A, and D, and stuff like that. So
Are you talking about hydrochloroquine?
that's the Plaquenil
Hydrochloroquine?
drug. That's the Plaquenil drug.
Okay. No, remdesivir?
Yeah,
Remdesivir?
that's the HIV drug. Yeah, that's what I believe it's called. Yep. But
Oh, okay.
since this disease is so new, they haven't actually been able to do clinical studies and trials to actually say this is working. It's just basically one of those things that it's like it looks like it's promising, but they don't have definite hardcore facts to say this is what works. We're gonna give this, and this is the regimen everybody's getting and everything. So a lot of the patients have not, in the different states and the different cities, have not all been given the exact same medicines. They have not all been given the same ventilator protocols. Because again, like I said, COVID-19 is a respiratory disease. It affects your lungs. Not everybody, because it's new, is treating it the same way. And that may have to do with the outcomes as well.
So listen, explain the difference between droplet precaution and airborne precaution, because initially I think we all had it wrong. We didn't know what it was. I mean, even now some people don't know what it is, and some people are just like, screw it, it's airborne because I don't know what it is. So explain the difference, what droplet precaution is and what airborne precaution is, and explain what COVID-19 actually is.
Okay, I'll actually do one even. First, I'll say contact precautions. Contact precautions.
Oh,
Yes, contact precautions mean it can come in contact. Like if you touch somebody, you touch a surface, actually physically coming into contact. That's contact precautions. Droplet precautions is basically if somebody coughs or sneezes. That if I was positive and I coughed on you, that it could be on you. Airborne means that when somebody coughs or sneezes, particles are staying stagnant in the air and slowly, after 2-3 hours, dropping before they disappear. So if I sneeze and I'm 6 feet away from you, 10 feet away from you, and I sneeze in the air, and 5-10 minutes later you walk in walk right where I sneeze with your mouth open, you can possibly get it that way, is what they're saying when they say airborne. So airborne is meaning that the droplets are staying in the air.
Okay. Oh, and then also explain aerosolized, because that's been a term that we've been hearing too. What does droplets being aerosolized mean?
So that means basic aerosolization is kind of like a cough or a sneeze. So aerosolized, like if you have a can of hairspray, right? When you spray the can, you're aerosolizing it, meaning you're dispersing it into the environment. So you're spreading it. So when someone coughs or sneezes, that's a form of aerolization. Also, a lot of times, what they're not doing in the hospital, when I was mentioning we were giving people oxygen, we were doing the nasal cannula and the non-breather, they weren't putting people on CPAP or BiPAP because that was a way where the disease was being aerosolized into the atmosphere. So you could be positive. Like, say, for example, your dad or your mom or even you might have a sleeping disorder. It's called sleep apnea. And you put a CPAP machine on. The CPAP machine, the word CPAP, CPAP, stand for continuous positive airway pressure. So it's blowing pressure at you. So if you're a positive person and we're blowing positive pressure at you, then some of those particles could get out into the air and aerosolize. So that's what that means. So aerosolization just means basically spreading into the air.
So, okay, this is what I want to ask you. Are you actually giving anesthesia to these patients who are positive or suspected for COVID-19? Because since the disease is, airborne, you can talk it and breathe it. I mean, that just puts you at a totally like astronomical risk. So are you having to do that, or no, you guys aren't doing surgery on clients that are positive?
So when the governor put the stay-at-home order, she suspended like outpatient procedures and stuff like that. So we're not doing any elective cases, meaning something that you don't have to have done. Like if you wanted to get a boob job or a nose job, no, you can't come to the hospital and get your boobs done or your nose done at this time. However, we're doing emergency procedures. Emergency procedures are procedures that you basically have to have done or you can die, or you have to have something fixed or you can die. For example, if you broke your hip, we need to fix your hip. Or if your appendix ruptured, we got to take your appendix out. So we're doing emergency procedures still. And they are testing patients. So you can have a patient who tests negative, you treat them like normal. You can have a patient who is before patients were tested, they were called PUIs, meaning patient under investigation.
Oh yeah,
A
yeah.
PUI, so they were somebody who seemed like they presented with symptoms. They may not have had the test or the results may have not have come back. You treated them as positive, and then you have people who actually are known positive. If they were a PUI, meaning patient under investigation, or a positive patient, we took extra precautions with our PPE, which stands for personal protective equipment. So we would have a gown on, gloves on. We would have a mask on, like an N95 mask, or like you could have those respirator masks where it looks like you're like in the army and you didn't give somebody some gas or something. And then you wear a face shield, so you're fully protected. And again, you have on your gloves, your scrubs, a gown over your scrubs, and shoe covers and all kind of stuff. Even the patients who were negative, we were still being cautious with and still like wearing extra stuff or two masks or whatever. We weren't wasting the specialized masks, but you may still just wear like two regular masks or something for somebody who was negative.
Okay, let's jump into these comments for a quick second. Let's see. What's up, Corey? He says, can you see these comments or no?
I can see. I can
Naeam,
see
can you see
Corey.
them?
Now that you just popped this up, it says, "Do you
Okay,
think
so
the
go ahead
Detroit?"
and read it and answer.
Okay. Do you think the Detroit health director is doing a good job with managing COVID-19 in the city of Detroit? What could the city of Detroit do better to protect its employees from contracting the virus so they can continue to serve the citizens? Um, Unfortunately, in Detroit, I do know that they haven't had an overwhelming number of cases, and they did not have enough PPE for the healthcare providers. So that's unfortunate because if you do not have the proper protective equipment, it's very unlikely that I can say for myself, if I'm not protected, I can't go and save your life. It's like basically BLS. Like you always make sure the scene is safe before you go and save somebody, because you can't save somebody if you can't even save yourself. You know what I mean? So it's kind of one of those situations that if they don't have enough equipment to protect themselves, then they can't do right by the patients. Plus, I do know in Detroit they had the patient to healthcare provider ratio was not a good ratio. Like I'm sure a lot of people saw that story on the news from Sinai Grace where the ER was overwhelmed and the nurses were saying they had 15 and 20 patients.
Yeah, and they
When,
quit.
yeah, when you have numbers like that, you can't even see everybody. So clearly the care is going to be very poor. So I do know that they try to disperse a lot of people into the area, that like by hiring a lot of agency and trying to give people increase wages to try to attract people to come to these different areas to better serve the community. But the biggest thing that number one that you would have to do is have the PPE. You have to protect the employees against the virus before they can help people. And then the second thing that you can do is give people the resources in terms of staff so they can safely take care of people. Because I've heard different sad stories in terms of your loved one's on a ventilator, and normally when somebody's on a ventilator, you're giving them we're giving these people medicines to keep them like kind of like in a sedated state, so they're not like over anxious anxiety, like wide awake on the ventilator. So we're giving some of these people medications to keep them kind of sleep. So with that being said, these patients aren't moving. When somebody is laying in the bedridden, if you know anything about people in nursing homes or whatever, you have to physically go in and turn these people like every couple hours so their skin doesn't break down. Well, with this disease being so
Right.
bad and people being so scared, people weren't being turned properly. It was just a lot of poor care going on, and it's just very unfortunate.
Wow. Um, let's see. Dina, she says that is dope. She's just supportive. Um, let's see. Joey says, my two good friends. Hey, shout out to you, Joey. We love you. Um, let's see. Steven has a question. You want to answer? You want to read and answer this question?
Okay, so for the intubation, yeah, what we would do is we would pretty much do if it was somebody who was awake, like say for example, Charmaine is how she is right now, but she's having trouble breathing right now, and she's got a mask on her face, and she's like paranoid, like, oh my God, please don't let me die. But she needs to have me put the tube in. We would definitely give her medicine to put her to sleep, and then to paralyze her to get the tube in. And then we would continuously give her medications to keep her sedated while the tube is in. So these patients, for the first quite quite few days, were completely sedated, because you wanted to give the body and the lungs a fighting chance, because you can't just put a tube in somebody and then 1 day or 2 days later be like, okay, let's pull the tube out. So we would give these people time to try to let medications that they're given work, to see what's going on with them. And then the people who we were able to get off the ventilators, they were seeing improvements in chest x-rays. Like they were doing daily chest x-rays, checking to see how their lungs were looking. Also, you can check by doing blood gases, ABGs, which stands for arterial blood gases, checking to see if their values are, if they look good or adequate. And then also on the amount of oxygen that you're giving to these patients, in terms of the flow of oxygen that you're giving. You can give somebody room air, like us right now, we're breathing what's called room air. It's only 21% oxygen. Initially, when we intubate all these COVID people, we're giving them 100% oxygen. It gets no more than that. 100% means that's the max. So if you're able to start weaning somebody off of that oxygen level to like 80%, then 60%, down to 50%, down to 40%, and their oxygen saturation, when you're looking at the monitor, you see a number. When that number is 92 or higher and they're on a low amount of oxygen, that's a good thing. So now you're looking at that. Um, you're looking at their chest x-rays, and if you start to see and feel like there's improvements being made, then we started to lighten up the sedation and then put these patients on modes where even though they're on the ventilator, they can breathe for themselves on the ventilator. So there's different modes that you can have on the vent. So now we put these people on spontaneous ventilation modes where they can actually breathe on their own, and then you can get a better picture of how would they do if you pull the tube based on what tidal volumes they're pulling, what their respiratory rate is, and then you also check their stuff like that. And then that's when we made the determination, like, you know what? I think this person will do good, and we pull the breathing. We had, unfortunately, had to put the breathing tube back in some people that we pulled the tube out immediately, 2-3 hours later, maybe a day later. And then there were quite a few people who we did not have to put the tube back.
Okay, listen, explain something about tube placement. Explain how that's not something where you just come in and, okay, boom, I'm gonna stick this tube in. Like, don't you have to get consent from the family? Like, what is that process like?
Okay, so depending on if you come in, like if me and you were to come in, we're in our right frame of mind, right? So we sign all these papers that say we want us to be ventilated if we can't breathe on our own. We want to be a full code status, meaning CPR, cardiopulmonary resuscitation efforts, meaning give me whatever drugs you need to give me to keep me living, whatever you got to do to keep me living, give me that. There are some people who, like older people, like they that are coming from nursing homes that are like 80 and 90 years old. Their DNRs do not resuscitate. They don't want to be brought back to life. They don't want you to do extreme maneuvers on them if they can't sustain on their own. Those patients did not get the ventilator. They did not get the breathing tube. So we did have quite a few patients that we did not give the breathing tube to because they were those statuses. Or we did have some cases where say your loved one, say you were the power of attorney over your grandma, and your grandma comes in and your grandma has dementia, meaning she's not in her right frame of mind. And we call you and we're like, oh my gosh, this is hi, this is Naeam from the hospital. We have you such and such here. We have you as the next of kin. Um, she's having very difficulty breathing. She already has renal failure. She already has these issues going on. Do you want us to put the breathing tube in? Some people would say, well, do you think that she will get off of it if we put it in? And we can give you what our judgment is, what we think would happen. And some of those people at that time said yay or nay to the breathing tube.
Okay. Let's see. Monique, she says, this is great info. I don't understand the process, but I did know that the vent was kind of the last resort. So yeah, you
that
did
is
it.
true, Monique. Yeah.
Let's see. Steven, he had another comment. He says, I've heard that Black males may be more susceptible to heart damage from COVID-19. Is that true? You want to answer that?
I can't say for sure if it's heart damage or if it's just Black males or just African Americans and minorities in general that have a worse outcome with the disease, because a lot of people who have gone to the hospital have comorbidities, meaning they have like high blood pressure, diabetes, asthma. They have other underlying issues, obesity. So they have other underlying issues. The disease attacks your lungs, and what your lungs actually produce is a receptor site that's on your lungs called ACE2. It stands for angiotensin converting enzyme, ACE. That's what it is. And so that affects people who have high blood pressure. So they have more receptors that are targeted. So that's why people who have high blood pressure, it's not good for them. And a lot of African Americans don't take ACE inhibitors. So that might put them more at risk. But the disease process, because it attacks your lungs, So you know your lungs give your whole body oxygen. So as your whole body's getting oxygen, your red blood cells, oxygen is carried in your red blood cells. So as the oxygen decreases in your body, the amount of oxygen in your red blood cells that goes to your kidneys, your liver, your heart, it's decreased. So when you have that decreased amount of oxygen going to your kidneys, that's why a lot of these people are put on like dialysis stuff. Their kidneys are going out, and when their kidneys go out, you have like multi-system organ failure and stuff like that. And even the people who unfortunately do survive this, some people will have underlying conditions like, like weakened hearts or weakened respiratory systems. Somebody may have never had oxygen before, but now at night they may have to wear supplemental oxygen or something like that.
So in simple terms, can you explain to them why does this COVID-19 virus, why does it go to your lungs and just cause basically all this chaos in your lungs?
Um, well, again, that's just where the virus lives. That's just what it attacks.
The mucous membranes.
Yeah, it attacks your lungs. It attacks your mucous membranes. It attacks those ACE2 receptors that are in the lungs. So it's a disease that's specifically attacking your lungs. And as it attacks your lungs and it decreases your oxygen levels, your oxygen now is circulating to the rest of your body poorly, which is causing the damage to the rest of the organs in your body. So again, this disease is just the disease that specifically attacks your lungs.
So this disease is very serious. This isn't something that we should just be like, oh, it's the same thing as the flu, because I don't think everybody has been really taking it serious. So just kind of explain, like, well, I guess you did explain how serious it is.
Yeah.
Basically, it causes you to have these symptoms where
With the
feel
flu,
like you can't.
with the flu, they have different medicines that they know can treat the flu, right? There are no medicines known that actually will cure this. So this is an incurable disease as of today. This disease is incurable. Unlike the flu, you can give people medicines and do different things. This, when it attacks the lungs, it is attacking the lungs and it is causing the virus to multiply in the lungs. And it's basically, if you have a sponge, you know how a sponge is kind of like solid. And as the
Right.
sponge gets older, it starts to get holy and stuff. And like,
Yeah.
So that's what it's doing to the lungs. It's taking out chunks. It's tearing the lungs apart. And the lungs are not an organ that just can like replenish itself and rebuild itself. That's why they say smoking is bad. Like you could smoke, and once you stop, you can have a little bit increased function. But if you've ever seen autopsy on people that were smokers, you could see the damage due to their lungs. Even somebody who has stopped smoking, there's still irreversible damage that has been done.
So should people stop smoking weed, or is it okay to continue smoking weed, or should we not take that chance? Like, what's your advice on that? Because a lot of people smoke weed, right? So does that mean that, since we got this virus in the atmosphere now, we should just totally stop? Like, what should we be doing? Can we continue to smoke weed, or are we putting ourselves at jeopardy and higher risk for having complications? I don't want to end up on a ventilator. I don't smoke weed, but I don't want to end up on a ventilator just because, I have this recreational habit. I like to smoke weed. And now that, I may catch COVID-19, does that mean I should stop? Because,
there are no reports that says that smoking weed enhances the likelihood that you would catch COVID, nor are there studies that suggest that if you have COVID-19, that would suggest that if you were positive and you started smoking weed, that it would increase the rate at which the COVID would attack your lungs. However, though,
but it compromises your lungs, though, right? Smoking weed.
Right. So what I was going to say is, if you were positive, I would not be smoking. I wouldn't smoke cigarettes. I wouldn't be smoking weed. I wouldn't be smoking anything if I were positive. Because if you're having trouble breathing, then clearly you don't need to be taking that breath to go and then blowing out if you're already having trouble breathing. But if you don't have COVID-19, smoking weed, smoking cigarettes, do whatever you do for yourself. But as we all know, smoking stinks. Smoking's bad for your health. But you know, people smoke marijuana versus cigarettes for different reasons. People smoke marijuana for glaucoma, to increase their appetite, to help with stress, to help with joint pain, and all kind of different things. So
Right.
yeah. But if
Steven
you
has
were positive,
oh,
I wouldn't be smoking nothing.
Steven has a comment. He says physical distancing. I wish they didn't use social distancing. Poor choice of words. What are your
Uh,
thoughts on that?
what words would you like them to have used then, Stephen? Because when they say social distancing, what they're saying is because we do know that the disease is spread by contact, meaning if I cough or sneeze and it got on a surface, it could stay on that surface up to 72 hours. We do know that a cough or a sneeze from where you're standing can go out into the air 6, 7 feet. So if you are right up on somebody and they cough and they had it, you didn't have a chance. So when they say social distancing, they're saying back up, give me some room because I don't know what you got. So it's for you to be safe and for me to be safe because it's kind of like one of those things. HIV, just think about it. Everybody who has HIV doesn't have a shirt that says I'm HIV positive. They can look normal. So these people that have COVID, a lot of people are asymptomatic. They don't even know that they're positive. So them not knowing that they're positive could put your health at risk. And that is what has happened.
Right. Let's see, Hey, Janet. Thanks for joining us. She says they have a vaccine. The government is lying to Americans. I sent you a video, Charmaine Bond. Please check it out.
Well,
So,
I
what do you? I mean, we've been hearing in different countries. Right now, I know that Johnson and Johnson is making a vaccine. There's a couple companies. What is it? Pfizer. I think they're making a couple companies are making vaccines, but as you know, they have to be tested and trialed and all that stuff. So I don't know that anything's out now. But what do you know?
Yeah, I haven't heard that there's an actual vaccine, and to say that they have a vaccine and the government is purposely not giving it would be like a conspiracy theory to me, and I'm not really a conspiracy theorist. I do believe if you want to ask me what are my thoughts in terms of where it came from and all that stuff, I can tell you where I think it came from and all that good stuff. But in terms of saying that they have a vaccine and they're just choosing just to let people die, I would like to not think that.
Sharon, hey Sharon. She says in the air, enclosed spaces, or outside too. Sharon,
Uh,
are you still on the thread? What do you mean by that?
um,
Where we go?
I guess what she means is when we say airborne, so a sneeze, when you sneeze, that those particles that shot out can still be in the air and linger for a couple hours or whatever. So that could even be outside. Um, Obviously, being outdoors would be a lot safer than being indoors. If somebody were to sneeze or be doing something like that. So outside is safer. That's why they're opening up everything in stages, like with the outside first, like allowing people to golf and boating and do different outside activities before they start to slowly open up, the rest of society.
Right. And did you hear them say at the president's briefing, the experts and everything were up there, they were saying that the heat, it doesn't survive. I mean, they said that the virus doesn't survive in the heat, in the humidity, ultraviolet rays. So they're saying that, talking, coughing, spitting, whatever, anything you're emitting droplets, it is basically gonna die like that if you're outside. So that was another part of the rationale, why they're opening stuff up outside. Do you believe that, or does that make sense to you?
In terms of saying the evaporation, again, it does seem like, stuff can evaporate. The hotter it is, stuff does evaporate quicker. Just think of in terms of water. If it's raining and it's 60 degrees out, how long does it take for the rain to dry versus if it was raining and it's 90 degrees out or 95? Those few droplets on the ground are gone much quicker than if it's 60 or 70. I don't know at what temperature it would evaporate or it would be safe, but yeah. It makes a little sense that if it's hot enough, it would be a little bit safer, that things would evaporate a little bit more readily. But again, I don't know how quick or if they've done a study on it. Like if they've said, okay, we're going to go into this sauna room or go into, you know, a controlled environment, and we got this patient who's positive. We want them to cough, and then they test the air to see how long those particles stay in the air for. I'm sure they haven't done that or whatever. So, yeah.
Yeah. So Sherman says, what's the protocol for patients with DNR or DNI? Did you explain that? If you did, then just kind of go over it again.
So a DNR means do not resuscitate, and a DNI means do not intubate. Somebody can be a DNI, mean they don't. A DNI just means that they don't breathe the tube. Generally, if you don't want the breathing tube, you're going to be a DNR too. But a DNI is somebody who does not want the breathing tube. And a DNI,
because how can you really save their life if you're not, you know, intubating them? Even if you push all these meds, it's like the airway and the heart goes together, so they stop breathing. You can't
exactly.
really restart your heart without,
right.
you know.
But did you remember basically when we used to be in the ICU too, people used to be like, oh, they're a chemical code only, or you would give them, so you could give people drugs in the IV, but you don't do chest compressions. So, yeah. But if you're a DNI and you got COVID and you need a breathing tube, you're going to die. I mean, it just is what it is.
Let's see. Sharon has another comment because incubation period at minimum 14 days. What are the symptoms to look for, or what to pay attention to in your body during the incubation period? That's a very good question. Do we even know if 14 days? Go ahead and answer that.
So I think the incubation period is actually 2 to 14 days. If you've got the 14 days, it's over. So 14 days would be the max. 2 days is like the minimum. And signs and symptoms that we know were coughing, which is really noticeable, fever, which is really noticeable. Some other ones that aren't as noticeable would be like diarrhea. People were complaining of loss of smell. People were complaining about
the taste.
Loss of taste. And people were also now pain, and people were also now starting to show like signs of strokes and stuff. Pink eye. I think those were the pink eye and all those other ones.
What was I gonna say? Actually, it's longer. Actually, it's longer than that.
That was another bit. Fatigue. So basically, just being completely weak and just having no energy. So
but listen. Actually, is longer than 14 days. There have been some studies that shown that people were still testing positive like after a month. So, I mean, is it really that 2 to 14 days anymore? I mean, I think the CDC is still saying that, but there's been some research. So, I mean, we just don't know.
So this is the funny thing that you probably have heard about. So they were saying for healthcare workers, if you tested positive but you feel good and you're asymptomatic, meaning you're not showing any of the symptoms, even if you tested positive, after 14 days, they had people coming back to work. So
that's BS. But hey, do you agree with that? How you coming back when you feel positive?
I know it just seems really like okay. But yeah, I actually work with some people who are positive and they back at work now. Mm-hmm.
Because I guess the theory
and you
is
be
like,
looking at them with the side eye like, girl.
Right. I guess it's like you working around positive, you know, COVID-19 positive patients anyway. So all y'all positive. So I don't know. I don't understand that. I don't agree with it, but you know, hey, we're in a pandemic, so all the rules are broken. Like Dr. Grace, oh, such a pleasure to see you on here. She says, not only smoking, what about cleaning products, bleach, ammonia, other lung irritants? Okay, want to talk about that?
Are you asking are you saying stay away from those things, like because that can irritate your lungs, or are you saying what are we doing to clean the environment and clean our areas?
Dr. Grace, if you're still on our thread, can you clarify that a little bit? We'll come back to you.
But yeah, in terms of cleaning and everything, we definitely used a lot of the bleach wipes. We've been using those hospital wipes, the purple ones, the sanitation ones. I'm not sure what's all in it, but they're the ones that you wear gloves on and you don't want to touch your skin and stuff like that. So we wipe like everything down. If I had a patient that was positive, we're using viral filters on our machine, and then after the case, we change the whole circuit and everything as well. So yeah, they've been cleaning
She
with
said,
yeah, a lot of bleach products. I'm not sure about the ammonia, but definitely bleach products. If you're at home and you couldn't get any bleach products because the stores were out of it, I guess ammonia would be the best next thing. Ammonia and vinegar and stuff like that. You know, those home remedies and home cleaning solutions grandma would come up with.
right,
Like a little bit of essential oil with a little bit of Dawn dish detergent with some water or whatever
right.
to clean your hands and stuff.
Dr. Grace says, what about asymptomatic carriers? Did you address that? If not, go ahead.
So asymptomatic carriers, they basically are people who are sign and symptom free and they don't know that they have it, and they are out there. They're people who, yeah, they're healthy. They don't know that they're sick, and they can definitely give it to you. So that's why we were saying about the social distancing. With the social distancing, it's given the healthcare workers a chance to catch up and take care of the people, and giving everybody a chance to stay home, stay safe, and kind of slow the spread of the virus. Because we know that the more people that are positive interacting are contacting each other and spreading the virus. So that's why you kept seeing all those signs that kept saying, stay home, give us a chance, give us a chance. Because if everybody is just getting to go outside and be buck wild and go to the mall and go to the movies as normal and go to restaurants, you're never going to stop the transmission of the disease. So that's what the social distancing about it is about.
Steven says um, it's literally physical. Socially distancing is traumatizing. Mental health problems happen.
Agree, Stephen. I agree. I can say this COVID-19 has not only affected. I don't want to get like all choked up. It has not only affected healthcare workers. It affects definitely families and everybody too. There, because during this time they've not allowed family to go to the hospital to be with their loved ones. That in itself is traumatizing for your mom, your dad, your grandma, anybody to die and die alone. That's traumatizing. So the nurses are traumatized by it as well, because what they've been doing, a lot of nurses have been, FaceTiming loved ones for people to say their goodbyes. I can say myself personally, uh, before I had put a breathing tube into somebody, I asked them, was there anybody that they wanted to call? You know, like, is there a phone call you would like to make? Is there somebody you want to talk to before I put this breathing tube in? Because unfortunately, the truth is, that could have been the last time you ever talked to that person. So that right there is traumatizing. So yeah.
Wow. Let's see. Um, Grace says the comments are delayed. Yes, I apologize. It's the software. There is a little delay, unfortunately. I had to, I don't know, maybe upgrade or something. Let's see. Steven says, wait, I'm trying to pop over here. Steven says the heat that kills the virus is 132. Yeah, I'm glad you asked that question,
Well,
because has been wanting to know, like, what temperature will kill COVID-19? Can we even pinpoint a certain degree of temperature? Go ahead and address that.
well, that's hilarious. That's what I was saying when I think you had asked it about how they were trying to open out the outdoors and saying that the heat kills it. I don't know what temperature that would be. And if he's saying 132 degrees, clearly nobody's outside in 132 degrees. We can't live at 132
Right.
degrees. So that means the heat ain't killing it where it's safe for us to go outside.
Yeah. Let's see. Dr. Gray, no, we good. I appreciate. Listen, I welcome all feedback. I need it. Trust me. Okay, so let me just go on with some questions that I also have for you. What demographics? Because we all want to know, like, who's dying of this? Who is the most impacted, infected? Is it Black folks? White folks? Is it just anybody? What types of demographics are you seeing the most?
So the demographics that I'm seeing the most, I would say, would be between like 45 and 65. If I had to pick, like if we were doing like age range charts And you
Right,
had to pick,
age range.
like, if you had to do like this age, this age, this age, I would say maybe like 45 to 65, or maybe even 50 to 70 if you were giving me 20 years that I had to pick a group. I would definitely say it's affecting minorities more. I've definitely seen a lot more, unfortunately, African Americans dying from this disease. But a lot of this has to do with,
Is it male or female? You seeing more women or more men?
um, uh, I haven't actually done a survey, but
Okay,
if I had to choose, like if I was betting, I would say maybe more men, but
okay.
definitely again more minorities. And the thing about minorities is the reason why it's affecting minority populations more is because it has a lot to do with socioeconomic status. A lot of minorities, unfortunately, are on the lower echelon of the food chart in terms of finances. A lot of minorities don't have, and again, this is kind of like, I'm not trying to generalize or stereotype, but the facts are the facts. Like, they don't have access to healthcare as readily. They don't have cars and transportations to get to the doctors and make their appointments. And a lot of African American people specifically suffer from high blood pressure. And this is one of those comorbidities that is very deadly for this virus. It actually kind of enhances it the way that it attacks the lungs. So I would say, yeah, a lot of it is socioeconomic status in terms of finances. And I think that's why.
Um, what are your thoughts on the nature of this virus? I mean, is this something that's just going to keep spreading and spreading and spreading until they get a vaccine that can help control it? I mean, because the whole debate now is, why are we in the house? You know what I'm saying? Like, shouldn't it be the people who are immunocompromised, or the people who are elderly, or the people who have these comorbidities? Shouldn't those be the people that stay at home, and everyone else who is healthy and what could be an asymptomatic carrier, put them in masks, gloves, social distancing, and let them go to work? Because I mean, at the end of the day, I mean, we're all going to potentially get affected. At least that's just how I feel. Just from statistics alone, we're already over 1 million people with the disease, and we know how contagious
3 million
it is.
now worldwide. I think it's over
Oh, it's
3 million.
3 million. No, I'm talking about in the U.S. In the
Oh,
U.S.,
over 1 million. Yep, over 1
right, over
million.
one.
Yes.
But yeah, you're
Yeah.
right, worldwide. So I mean, and yeah. So what is your opinion on that? Like, how long can we really just stay in the house? I mean, hiding from this virus when it's everywhere. We just have to eventually adjust our lives, right? I don't know. What do you think?
I definitely think a lot of it is going to be an adjustment. People are definitely going to interact a lot different than they do. It ain't gonna be all about, oh, hey, how you doing, girl? Kiss, 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 hug, hug, hug. People gonna be giving daps with elbows and stuff, probably, definitely, excuse me, for the remainder of 2020 or up until a vaccine comes out. The disease, it doesn't say you're this age, I'm just going to get you, because there are definitely young people that have had it and young people that have died that had no other underlying issues. Like they were like no high blood pressure, no diabetes. They were like young healthy people that got this disease and died. So you can't just say that it only is going to attack a certain demographic. Even though a certain demographic may be more at risk, it doesn't say that it ends there. So again, you have to be safe and smart about what you're doing. So that's why right now we're being safe and smart. And I think the governor did a great job by extending the stay at home until May 15th, because she's giving it more of a chance to get a grip on it, to give the healthcare systems more of a chance to get these people better that are going to get better. The people that aren't going to get better, they pass away, or the people who are going to be placed into long care ventilator programs or whatever, they can go there. And so we can slowly open up the economy,
But
in a safer way.
But Mayor Duggan announced today that there's 700 beds around the city, 700 adult beds around the city of Detroit, and that there's 100 ICU beds around the city of Detroit, and that hospital admissions are down. So what
Hospital
would
admissions,
explain that?
Hospital admissions are down. I can even say definitely for me, the amount of people that I've been intubating, put in the breathing tube over the last week to 2 weeks is definitely decreased. That I would say would be largely contributed to the stay at home social distancing. Everybody's not at the movie theater. Everybody's not at the mall. Everybody's not at the restaurants eating. Everybody is basically, there's nobody out. There's nowhere to go. So the people that are probably popping up sick are people who are healthcare workers that are around people, or somebody who wasn't social distancing or something like that. But that's
But
why
I
you're
thought
seeing
the
such
whole
a
goal, I thought the whole goal was to not overwhelm the hospital, which we've done because y'all got PPE, y'all got ventilators, y'all have everything that you need. Admission is down. We're closing up hospitals. I feel like we met our goal. So now that you met our goal, why are we still in the house? I mean, I'm just asking these questions. I'm not trying to
I get it.
get
I get it.
political.
The reason why is because you can never put a price tag on somebody's life. Somebody's life, your mom's life to you is priceless. My mom's life to me is priceless. So if it takes you staying in the house 15 more days to keep my mom alive, that's small potatoes. So I think the bigger picture is to save more lives. It's not about getting the economy back on track or whatever, because what's going to be is going to be. But in terms of saving lives, I think her goal and her biggest thing is she's trying to save as many lives as she can. And by giving the virus more time to die down, if it has nowhere to go, right? Because less people are being affected, it's less people that can spread the disease. And as you
I
get
just feel
more,
like it's lengthening it, because when we all come out, the virus is still gonna be there. I don't know. That's just my personal debate, but we can move on. I get it.
yeah, I mean, you're never going to be able to eradicate anything. That's like
Right.
with STDs, that's like with anything. But knowledge is power. So now you're right. We're not going to be able to eradicate it. We are going to eventually have to start opening everything up. But we're giving companies more time to build more ventilators in case when we open it back up, this happens again. We're giving companies more time to make more PPE so that we don't run out if this happens again. We're just, I just think she is
Yeah.
being more, it,
um
and you do know Michigan in terms of the numbers of people that had it and died. Michigan is like the highest in terms
right.
of the
Right, we are out of all the
right.
states. I want to say I think we're like 7th for cases, in terms of people being infected, but in terms of people dying, we're like the 3rd. So yeah, we had the most deaths.
Right. What I'm
Sad.
talking, yeah, because I'm talking about like if 4 states have 40,000 positive cases, Michigan got 40, Illinois got 40, Alabama got 40, Louisiana got 40. I'm just using an example. Michigan had 3,000 people die. This state had 2,000 people die. This state had 1,000 people die. This state had 500. But all of us have 40,000 positive people. That's what I'm talking about. And that's,
Right. Yep. I got you.
yeah.
Dr. says African Americans have a symptomatic high blood pressure, the silent killer, plus COVID-19 equals increased death rate among African. Yep, that's true.
Yes. Mm-hmm. Yeah.
Let's see. Stephen has a question or comment. He says there are groups creating free scripts, no insurance testing around Detroit. This has been seriously needed. The CCCN State Fairgrounds has stipulations that have kept some from being tested. You want to answer that? I don't know anything about that.
I'm gonna just say that's a true statement. I don't think he was asking us anything. I think he was just making a statement.
Oh,
That's a true statement. Originally, when the virus came, they didn't have enough tests to give people. So that's why only certain people were being tested, and you had to meet all this criteria before you could be tested. But now that they've gotten more tests readily available, they are testing a lot more people. Even at my hospital, they told us that before they open up surgeries, that all the employees will be getting tested. Like I personally have not had a test yet,
yeah.
but
Let's say, have you been tested? You haven't been tested?
supposedly our staff, the hospital will be tested. The staff that works at the hospital will be tested, but we have not been tested as of yet. Unless you were
Oh,
somebody who want and sought out the test because you felt like you were exposed or you had symptoms or something. But in terms of
so what are you doing to keep safe, and is that enough? I mean, because you're in direct contact, with these people airways. And I mean, tell them exactly everything you got to put on, all of the clothing and garb, walk us through
Yeah.
that, what it's like.
So if I'm dealing with someone that is a patient under suspicion or a positive patient, um, actually anybody that I'm going to intubate now, I have on gloves, I have on over my scrubs, I have on a jacket and a gown, I have on my mask, and I have on goggles.
What is that
And
mask you have on? It's like got these gray things.
it's called an P95. It's like a respirator mask. It's a P95. They have uh, P100s and N100s.
Uh-huh.
But and after I intubate the patient or whatever, I'll get rid of the gloves. I'll get rid of the gown, and I'll take a wipe, like a bleach wipe or a disinfectant wipe, and wipe off my shield, and then I'll wipe off my little mask around the area and stuff like that.
Do you wear shoe covers too? Shoe
I, do-
covers?
I wear shoe covers, but I don't change
You
those
wear
until
shoe covers.
yeah, I throw those away at the end of the day. I don't replace the
So
shoe cover.
what's your decontamination process when you get home? Because I'm sure you don't want to bring any of that stuff, because I mean we don't know if it can get on our hair, or we just don't know. We got to be
So
extra cautious. So what do you do?
so I actually have my hair is braided, so I wear a wave cap on my hair, and then at work we also have caps. So you throw your disposable cap away at the end of the day. As soon as I come home, I have Lysol, like a personal Lysol, and wipes in my car and everything. But as soon as I come home, I wash my hands frequently. Um, the first couple weeks I was washing my hands so bad, they were like dry and skin cracking. Um, but now that things have kind of died down a little bit, I don't wash them as much, but I still wash them a lot. But as soon as I come home, I strip right at my door. I take my clothes off right at the door and then go get in the shower.
Okay. What about the vaccine? What are your thoughts on vaccine? It's a lot of people who saying they ain't messing with that vaccine when it comes out. So
Unfortunately, you even know this, Charmaine, being in the healthcare setting, they make you get a vaccine. So you have to get the flu vaccine unless you have, um, uh, if you tested,
test X-ray.
like unless you had a chest X-ray, you had like a reaction to it. They make you get the flu vaccine, and it would be the same thing with this. If you're working with patients and you're in the hospital, they will make you get the vaccine. And if you choose not to get a vaccine, then they'll probably make you sign some papers, and then you're always going to have to wear a mask nonstop, or
Yeah. No. What is your advice to like the public in terms of, getting this vaccine when it comes available? Would you recommend it or you don't recommend it?
Um, if it's a vaccine that you can, like, if it's a vaccine that you're saying that you could take it um in advance to not get sick, I would say get it. But if it's a vaccine that you can get after you get sick, then I would say don't get it, because like if I can easily give you this vaccine, like, oh, you got COVID, here's the vaccine, and now you're fine, then I wouldn't necessarily see why you need to get the vaccine. Does that make sense?
Yeah, but normally that's not how
I know,
vaccines work.
I know, right? It's like HPV. You get the HPV vaccine before you get it, because once you get it, you screwed. So you're right.
Right, right,
So
right, right.
if that were the case, if it wasn't something that could be treated, if they don't have a cure for it, I would get the vaccine. I would recommend the vaccine.
Um, what is your advice on wearing masks? Because there's some people out here like, look, I'm not gonna wear no mask. I don't care, if I get it, I just get it, but I'm not about to wear no mask. So are you wearing masks when you go out? If you have to go to, Walmart, Kroger's, wherever, are you wearing masks?
The only
So
time
what's your recommendation to the public,
the,
in
my
terms of wearing?
my recommendation is be safe. Why even take a chance? How valuable is your life? Or how valuable is your life to your loved ones? Like, why even take the chance? Like, just just do it. Like, I would just be safe with everything that's going on. Maybe months down the road, if they get a handle on it, they get a vaccine. Okay, but for right now, especially if when they do start to open up, they're going to probably mandate that you have a mask on. So if you think you're gonna be going to J. Alexander's or PF Chang's to eat, you're not coming up in here without no mask on. And I know you're like, well, how can you come in here without a mask on if you're gonna be eating? They're gonna be like, take your mask off, take a bite, put your mask back on. But but no,
Yeah.
I'm just being silly. But I do currently, since it's recommended and I want to be safe, I do wear a mask when I'm out and about. The only time I don't have a mask on is if I'm in my car, at home, or if I'm visiting my parents or something, since I feel like I'm asymptomatic. And when I say asymptomatic, I feel like I'm COVID free. But I don't hug and kiss my mom when I go over there. I don't go, I like kind of like am 6 feet apart a little bit for the most part. Like when we're watching a movie or whatever, they're on one side of the room, I'm on the other side of the room.
Are you at home? You got a nice house.
Thank you. I I wash my hands. They'll wipe the door down with the Lysol wipe or something when I come and go or whatever. So I'm not touching anything. And like I said, I haven't been kissing and hugging them since this
Yeah.
has started, since I'm working in the hospital and stuff like that. And if I ever felt like I was sick or whatever, I definitely would not go over there, period. But I haven't, had a cough or sneeze or any of that stuff. So I've been feeling good.
What's up with these videos I've been seeing you make dancing and stuff? You trying to audition for Dancing with the Stars? Or you just having a little fun at work?
Just having some fun at work. Just, everybody's been at home. So everybody was making these videos and just to lighten the mood and cheer everybody up. And I like to dance. So me and my girl were like, oh, we should do some dancing videos, whatever. So we were doing like the little Savage Challenge and all those other little
Yeah.
challenges. Yeah.
That's what's up. So before we go, leave everybody with some, tips. What do you want to tell people to help stay healthy?
Basically, knowledge is power. So know your body. Know your body in terms of if you're not feeling well. To stay free from a temperature, a fever. If something changes in your body, then you need to go and do something. Don't try to be a hero and stay at home and be like, oh, if you feel like you're having shortness of breath or whatever, go and get checked out. But the things that you can do is when you're in the public, wear a mask, wash your hands frequently, social distance. I personally have been increasing my intake of vitamin C, vitamin D, and drinking fluids all the time. I drink like, I don't know, every couple hours. I'm making sure that my mucous membranes are nice and moist. As soon as I get off the phone with you, I'm gonna go have some hot tea. So just trying to be
Should
healthy.
people just be getting tests just willy-nilly, just let me just get it just to see if I have it or not? Should people do that or wait until they have symptoms? What would you advise?
I don't see the point of getting tested just to get tested. If you needed to get tested in terms of going before you go back to work, if it was a requirement before you go back to work, then clearly you would get tested. If you really feel like you have it and you're asymptomatic and you just have OCD, which is obsessive compulsive disorder, you just really, you know what? I just gotta know. I gotta know. Just for your own mental sanity, go get tested. But I don't know what you would just get tested for, just to be like, let me just see. Like, this is gonna be the COVID challenge test. Let me go get one. Like,
You are hilarious. Listen, Naeam, oh my gosh, it was such a pleasure to catch up with you from all these years. You've been great. You've been very informative. We got lots of comments on the thread, so I'm sure it was valuable. Listen, you have a great rest of the evening and stay safe in